Hello, I'm Jacob Honeyman. I'm a PGY2 internal medicine resident at OSU Medical Center. I'm a part of the OSU Medical Center Transfusion Committee, and I bring a project called the Iron Rule: Treat the Cause, Not Just the Count. The objective of our study is to implement an Our Practice advisory that helps detect when a patient would benefit from iron studies prior to receiving blood products. So, really, the goal and aim of this study is to reduce the number of unnecessary red blood cell transfusions in this process from early detection and treatment of iron deficiency anemia. Iron deficiency is literally defined as low levels of serum iron, serum ferritin, and high levels of total iron binding capacity. And this is a common finding in and out of the hospital, of course. Treating iron deficiency in inpatient settings appropriately has shown to reduce the risk of need for blood transfusions. Iron supplementation has multiple forms, of course. Oral is very cost effective, but some people do require IV iron infusions who cannot tolerate that. Of course, iron infusions have their own drawbacks of infusion reactions and anaphylaxis. And our patient advisory is defined as notifications that appear in an EMR that are triggered by certain subsets of values that meet certain needs. If certain criteria are met, the alert will pop up and page the provider to consider ordering certain things, such as our standpoint here. Other examples that we see commonly are sepsis, electrolytes, allergies, side effects, drug-drug interactions, etc. So our methods are kind of go in phases here. So there's pre-data implementation plan, then post-data um, extraction from there. The graphs below are retrospective data that we obtained from April 1st, 2025 to October 30th, 2025. And this is prior to creating our OPA. So variables collected included packed red blood, packed red blood cells transfused, presence of iron studies, and then analysis included the frequency of iron studies prior to transfusion, proportion of patients meeting criteria for possible iron deficiency anemia, and total packed red blood cells used during each encounter. Our implementation plan will include a creation of the Our Practice advisory, and this advisory will be triggered um, when anyone initiates a packed red blood cell transfusion and that a patient that hasn't had iron studies in the last 30 days. This alert will recommend consideration of iron studies, of course, and there will be overrides offered for emergencies such as hemodynamic instability and active hemorrhage. We also plan on adding iron studies to the pre-transfusion labs drop down on the blood administration order set. We really want to complete this data by June 2026, of course. And then after we implement this BPA or OPA, we will reevaluate the data at our center to see if our patients benefit from the early detection of iron deficiency and really overarching see if the red blood cell administration numbers are improved. So here on graph one, you can see our pre-administration data here. So there were 316 blood transfusions in our time frame, and 138 of them um, received iron studies prior. So that was up 43.67%. And there were 316 people in our system that had an incomplete iron evaluation during that time frame as well. Figure 2 over here shows their pre-transfusion lab dropdown. So really, as far as next steps go, we're analyzing the early detection benefits of iron deficiency anemia and its overall effect on unnecessary red blood cell transfusions. Once we implement this OPA, um, We'll analyze this data and see if we're reducing red blood cell usage in our hospital. We have future direction, including education via lectures, emails, and handouts on correctly obtaining iron studies and use of blood transfusions, of course. Thank you.